Hi everyone, we're just going to give people a couple more seconds and then we will get started. All right, so it looks like we're going to get started now. So hi everyone and welcome to another one of Wellspring's Be Well Wednesday Talks, an informational webinar series that discusses a wide range of topics related to the experience of cancer. And so today's topic will be sleeping well with cancer and beyond. And just before we do get started, I just wanted to take a minute to review some housekeeping points just to make sure the session runs as smoothly as it can. So because this is a webinar, we just wanted to let you know that you currently are on mute and videos are disabled, and you will only be able to see and hear the speaker. Next slide, please. And so there will also be a question and answer segment at the end of the session. So at the bottom of your screen, you should see an icon that says Q&A. And next slide, please. You can click on that icon and you can submit your questions, type them in here, and you also have the option to send them in anonymously as well by checking off that tick box. Next slide, please. And so all questions will be addressed at the end of the presentation, and we'll try to get to as many questions as we can, but feel free to send in your questions throughout the presentation, and we'll just address them at the very end. Next slide, please. So this webinar will also be recorded and uploaded on our Well on the Web. Next slide, please. So you can view it again if you do have to step out at any point in time. Feel free to check the self-paced learning section of our website, and the talk will be there in a couple of weeks. Next slide, please. Perfect. So I'm very, very excited to announce our speaker for today. Today we have with us Sheila N. Garland, and Sheila is a registered clinical psychologist. She's also a senior scientist at the Beatrice Hunter Cancer Research Institute and an associate professor in the departments of psychology and oncology at Memorial University in Newfoundland. So Sheila, I'm happy to pass over the presentation to you.
Thank you. Thank you very much. I'm happy to be here. I love that we're able to access more individuals and make supportive care programming available to more people when, as we were sort of discussing prior to the presentation today, sometimes, things are not as accessible elsewhere in our lives right now. So very fortunate to be able to come and be able to talk with you about something that is really important to the work that I do and very important to overall kind of cancer recovery. And that is sleep, and specifically when it comes to cancer-related insomnia. And the objective of what I'm going to be talking about today is really to help you have an understanding of kind of how sleep can become disrupted when cancer kind of gets thrown into the picture, and give you some practical take-home strategies to either work on this on your own or kind of where to go for some additional help. So I first want to spend a little bit of time just sort of talking about what is sleep. Sleep is one of those things that I don't think many people think too much about until you aren't able to get it like you used to. But when you take a step back and you consider what is sleep, sleep is pretty interesting in the fact that it's universal among most of the animal species, and from an evolutionary perspective, sleep really appears to be a pretty stupid thing to do. All right, so if we're sleeping, we can't gather food. Sleep makes us pretty vulnerable. We can't defend ourselves against predation. We can't find a mate. We can't reproduce. So these are things that are all kind of life promoting, but sleep is taking us out of these activities for at least a third of our day. So, and every species that has been studied has its own version of sleep. So some are more similar to ours than others. And I think we've only started to understand and appreciate how vital sleep is for just the entirety of our organism. And there does not appear to be one major organ or process that is not impacted by sleep. So I'm going to be describing some of the most important functions. So, to give you a definition of kind of like what sleep is, because I think normally people would think about, oh, yeah, sleep is just something I do when at the end of the day. It's, what happens when I lay down and close my eyes. Sleep just happens. But there's actually a pretty detailed and rather complicated definition of sleep. And so I'm going to break this apart into its components. So, sleep has been defined as a recurring, reversible, neurobehavioral state of relative perceptual disengagement from and unresponsiveness to the environment. I'm going to break this down, so don't worry. Sleep is typically accompanied in at least humans by postural recumbence, behavioral quiescence, and closed eyes. So, so when you think about a pretty complicated definition like that, and maybe the definition we were thinking about before being like, oh, okay, sleep is just something that happens when I close my eyes at the end of the day. It's pretty different. So if we break it down and just say, okay, what does that actually mean? Sleep happens more than once. It's recurring. It happens at least in humans, at least every 24 hours, and it follows, a fairly predictable pattern. It's reversible, so we can wake up from it. Neurobehavioral means it involves both, behavioral signals as well as, specific brain states. This state of relative perceptual disengagement means that while we're sleeping, our senses are muted. But that doesn't mean we're completely disengaged. We can still be activated by strong signals from the environment. And then, we typically sleep in a certain posture. We sleep in a reclined position, and we are inactive or motionless, and we typically close our eyes. So, yeah, when we go a little bit more into the details, I wanted to tell you about some of the specific sleep states and stages. And this is important to understand because if we understand how healthy sleep works, we can understand how sleep might go wrong, especially, when you have a diagnosis of cancer or cancer treatments in there too. So we have four sleep stages and two sleep states. So the sleep states are non-REM and REM stands for rapid eye movement. And non-REM includes three stages. So in our stage one, this is represented here by this graphic. And what you're seeing, these little lines here are EEG measurements. So that's measuring the electrical activity of the brain in certain brain areas. And so the electrical activity of the brain, when we're relaxed but we're awake, our brains exhibit particular patterns where the brain waves are really tight, condensed, and really close together. That means a lot is kind of going on in our brain. And you can see as we progress into deeper sleep stages through stage 1, 2, and 3, our brain waves actually kind of expand and get bigger. They slow down. Our brain actually slows down during these deeper sleep stages. So during stage 1, this is our lightest stage of sleep. This is characterized by a low arousal threshold. So if somebody calls your name, slams the door, you're more likely to wake up. If you might actually feel like you're not actually sleeping, but you are sleeping, that's where that sleep state misperception comes in. You might actually feel like, you're not sleeping, but then somebody says, no, you were sleeping. Or you might experience what's called hypnic jerks during this time. And that is where you might experience a sensation of falling, or you may not be aware of the falling sensation, but you might kind of feel your body like jerk back up. That's all indicating that you're in stage 1 sleep. Stage 2 sleep, I consider to be more of a transition period, right? It's got these really concentrated kind of pockets of electrical activity that's called sleep spindles, and these other particular kind of K complexes, these big K complexes, which are similar to the stage 3 sleep. It's kind of a transition. It has some pretty important components with regards to, memory and whatnot, but that's a little too detailed for what we want to get into today. And then stage N3, this is what's called slow wave sleep or delta sleep, because that's what these waves are characterized as, are delta waves. This is the stage of sleep actually that our body undergoes the biggest sort of repair and restoration. So the repair and restoration of our body is prioritized during this slow wave sleep. This is the stage of sleep. Kids get a lot of slow wave sleep. If you can think about, a child who, might be at a party, an adult party or something like that, and they end up falling asleep underneath a table and their parent sort of picks them up, throws them over their shoulder, puts them in the car seat, takes them home, puts them in bed, right? Like that's the kid who is really hard to wake up, indicating that they're in more of a deep delta or slow wave sleep. If you were to be woken up from that slow wave sleep, you would be very confused because your brain waves here are very slowed down compared to when you're awake and you're relaxed. You'd be confused, you'd be, who am I? Where am I? Who are you? What am I doing here? It would take you some time for your mind to kind of get up to be like, oh, okay, I'm kind of more alert. I'm more awake. My mind can function a little bit better. And then the second sleep state is REM sleep. And this has both tonic and phasic components. So the phasic component, is characterized by rapid eye movements, maybe some little kind of twitches in our muscles. You might see this in cats or dogs, right? Where, they might vocalize a little bit. They might be moving their toes. They might be moving their whiskers. Same thing. We actually experience that as humans as well. And then there is tonic REM, where we actually experience atonia. And atonia means we can't move our body during this time. So some people have described this as the old hag or sleep paralysis. So it's absolutely normal for when we're in REM sleep for our brain to basically shut off the body's ability to move its major muscle groups. REM sleep is associated with the most of the emotional regulation and the most vivid dream imagery. We do dream in the other stages, but the dream content in REM sleep is much more vivid and much more emotionally charged. So, it's thought that that sort of inability to move our major muscle groups during REM sleep is protective. So we don't want to be able to get up and act out some of these dreams that we might be having during this time. So, in the tonic REM, that's when we are not able to move our major muscle groups. But sometimes the front part of our brain, which regulates more of our awareness, kind of wakes up before the back part. And so we might be aware that we're awake, but we can't yet move our body. And so that's where people can experience that sleep paralysis for that temporary period, which can feel like a really, really long time, but it's usually, less than 30 seconds where we are not able to move our major muscle groups. So we typically sleep in a standard sort of pattern throughout the night, and that's called sleep architecture. So what I'll show you here is, the way we progress through the various sleep stages differs where you are in the night. So here you're awake for a brief period of time, and then you fall asleep, you bypass REM, you go into spend some time in stage 1, 2, and then here's the slow wave deep delta sleep, and then you come back up, have a little REM episode here, bypass stage 1, have a little bit more stage 2, and then more stage 3 and 4 sleep, come back up, have a longer REM episode. You might wake up there. Typically that's around 3 o'clock in the morning for people who can't sleep, because they all say, oh, I always wake up at 3 o'clock in the morning. So for some people, it might be just to turn over, it might be to go to the bathroom. Anyways, they fall back asleep, spend some more time in 1 and 2, have REM, 1, 2, maybe another little awakening, check the clock, back into 1, 2. And then here is a longer REM episode, down to stage 2, and then awake. So if I were to put a line right down the middle of this figure here, you can see some pretty clear differences between the first half of the night and the second half of the night. So in the first half of the night, our body and brain is really prioritizing that deep delta sleep, that slow wave sleep. And as I mentioned, that's the stage of sleep that's primarily responsible for the repair and restoration of the body. So, the body's saying, like, all right, you know what? It's never guaranteed that we're going to get enough total sleep time. So, we're going to make sure your body, your physical abilities, they're prioritized during that time. Now, towards the early morning hours, that's when you start getting more REM sleep. Now, REM sleep is more of the emotional and the cognitive, right? So, the emotional regulation and the memory, the consolidation, the attention, those sorts of things. So, this is why oftentimes you'll remember what you were dreaming about because you would have woken up closer to having a REM episode. And it's easier to wake up. From a REM episode than it is from a deep sleep episode because the electrical activity of your brain during REM sleep is very similar to the electrical activity of your brain when you're awake and processing. So it's easier to wake up from these lighter sleep stages in the morning than it is these deeper sleep stages, towards the beginning of the night. So your body is sort of prioritizing different things at different times. And it's also sort of making sure that everything is balanced. What's really interesting is that if you don't, for some reason, get enough sufficient sleep time one night, your brain the next night will spend more time in whatever you didn't get the previous night. So it's always sort of operating on this like homeostatic mechanism where less is followed by more is followed by less. So, if you are particularly tired, you have been awake for a long time, what happens is you actually tend to fall asleep quicker into this deeper sleep stage, this delta sleep, and stay longer in delta sleep. For some individuals who, have sleep apnea is characterized by difficulty achieving some of these deeper sleep stages, particularly REM sleep. They'll enter into what's called REM rebound because their brain has been deprived of REM sleep if their sleep apnea has been uncontrolled. So, their brain will go into REM sleep and they'll stay in REM sleep for a really, really long time. So the brain has this way of sort of getting what it needs depending on what it's given. So our sleep does change across the lifespan, but maybe not to the extent that a lot of people think. So here on the side is the amount of total sleep time we tend to get in minutes. And then down on the bottom is our age in years. And then the different patterns are the different types of sleeps or the different stages of sleep. So here you've got your slow wave sleep, your slow wave delta sleep, your stage 2, your REM sleep, your stage 1. This is the amount of time you spend in bed, and this is the total time in bed. Or this is the amount of time you spend awake in bed, I should say, and this is the total time spent in bed. So if you see the biggest changes as we age is not the time we spend in stage 2 sleep. It's not the time we spend in REM sleep, and REM sleep is responsible for the more of the cognitive and the emotional components. We do spend a little bit more time in stage 1 sleep. That's the lighter sleep. The biggest changes is we tend to spend more time awake in bed. And we also tend to get more or less of this delta sleep as we age. So again, that's the stage that is responsible for physical repair and restoration. And it makes sense, right? Our body just doesn't bounce back. It doesn't heal as it used to. And, that is due, at least in part, to the fact that our body just doesn't spend as much time in that stage of sleep that is responsible for repair and restoration of the body. In terms of total sleep time, that also doesn't change too much once we hit adulthood. So here we've got the sort of ranges that would be considered average in the blue, and each is sort of winged by what might be acceptable, not for the minority of people. So, once you get to be adults, 6 is kind of the minimum. We have good evidence, at least epidemiologically from big population-based studies, that anything less than 6 hours is associated with more physical and psychological health concerns. And then also, anywhere over 10 or 11 hours also can be associated with adverse health outcomes. So that's why we have a range here of about 7 to 9. Older adults, older than 65, maybe an hour less, but if you were once a 7-hour sleeper, it doesn't then make you a 4-hour sleeper, right? Like your sleep doesn't change that dramatically. And mainly what happens is as we get older, we may not be as busy, we may not need as much sleep. So there may be some reasons why sleep need changes as we age. So there are important factors to consider when understanding what regulates our sleep. The first one is something called sleep drive. Now, this is probably, I'm going to talk about two things, and these are probably one of the most important things to understand when considering what influences our sleep, what controls our sleep. The first one, as I mentioned here, is sleep drive. And this is something that is controlled by a neuromodulator called adenosine. And this accumulates in our brain the longer that we're awake. This is responsible for increasing our sleep drive. And if you think about sleep drive or sleep pressure, it's like the longer we haven't slept, the longer, the more pressure we have, the more drive we have for sleep. It would be the same as, the longer we haven't eat, the more our hunger increases. So sleep drive is something that is really, really important. And it explains why, it's really hard to fall back asleep after you've had a full night's sleep because you just don't have enough sleep drive. So the sleep drive increases from the time we wake up in the morning. It starts increasing. So for example, if somebody sleeps in, their sleep drive actually starts accumulating from the time they woke up. So this is why somebody can have trouble if they have one schedule during the week and then another schedule on the weekend where they sleep in. So if everybody's used to going to or waking up for the day at 7 and on the weekends they sleep in until 9, but then they find on Sunday night they have difficulty falling asleep by, about 2 hours, it's because their sleep drive started accumulating from 9 and not 7. So everybody can do the math for themselves. But for example, if you are a 7-hour sleeper, if you take 7 away from 24, you're going to need 17 hours of sleep pressure to build from the time you wake up to the time that you will be, approximately ready for sleep. So it is actually the morning anchor that determines your bedtime and not the other way around. A lot of people are told incorrectly, oh, you should just go to bed at the same time every day. And that's backwards. It's the morning wake up time that determines the bedtime based on sleep pressure. So if anything, we need to make sure that our wake up time is consistent to make sure we have a consistent bedtime and not the other way around. So you want to use this to your advantage, right? As I just did. So what am I typically? What sort of sleeper am I typically? Decide on what you want for your wake up time. Subtract your sleep duration from that wake up time, and then you have an estimate of when you're likely to go to bed. So for example, if I'm a 7-hour sleeper and I want to wake up at 7 o'clock, that means my bedtime is going to be around midnight. So if I wake up at 9, I'm reliably going to be pushing my time to fall asleep until 2. So this can explain why some people, just by switching around their morning wake up time can experience difficulty falling asleep. And without an understanding of sleep drive, they may misinterpret that to be like, why am I having trouble sleeping, right? I always go to bed at this time. So what you want to do or not do, so there's a number of behaviors that weaken the sleep drive. Spending excessive time in bed, that doesn't help. Just because you're in bed, it's not necessarily a cue for sleep if you don't have appropriate sleep drive already built up. If you're napping either too long or too close to your bedtime, you are taking away the sleep drive that you need in order to fall asleep. Now, I distinguish napping from dozing because a lot of people will say, I don't nap, but when I ask them, okay, well, do you doze? Like, do you just kind of nod off, watching television in the evening? And they'll say, oh, yeah, almost like embarrassed to admit that they do. That also counts. It's those little micro sleeps. and then sleeping in on weekends, as I explained. Now, the other kind of complement to this, what's also very powerful is our built-in circadian rhythm. So this is a circadian clock. It's maintained in the hypothalamus of the brain, and it controls the timing of sleep. And this clock, it doesn't care at all whether you had sleep the night before or how long you've been awake. So it promotes alertness independent of what else you've been doing. And it is controlled by the wake and dark cycle. And it also regulates our feeding patterns, our core body temperature, the brainwave activity we have, the regeneration of our cell, hormone production. So a lot of functions in our body are programmed to be performed at certain times of the day. We can entrain our circadian rhythm. We can really optimize our circadian rhythm by waking up and getting out of bed at a regular time. Making sure that we get light exposure in the morning to really reduce any production of melatonin, really providing clear indicators to our body that it's time to be awake, and then making sure that we don't provide incompatible exposures for our body. So we don't want light prior to the bedtime, but we do want light when we wake up in the morning. And also having regular other activities. So, that the body knows when it's going to be fed, the body knows when it's going to sleep, the body knows when it needs to perform. All of the regular activities, the body performs well when it knows what's coming. So if you see these sort of like working in harmony here, here's just 2 days, so over 48 hours. So 7 o'clock in the morning to 11 o'clock at night, wake, followed by an 8-hour sleep period, and then the next thing happening here. So this is our circadian rhythm. Our circadian rhythm, as I said, promotes alertness. And so it's going to, start from when you wake up in the morning, it's going to start sending out alerting signals. So it's alert, 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 alert. This is why even if you, let's say we're a night shift worker and you didn't work or you didn't sleep all night, it's very hard to sleep during the day when your circadian rhythm is putting out all of these alerting signals. It's telling you to be awake, no matter how much sleep pressure or how little sleep you had the night before. So it's sort of peaking in the middle of the day, promoting alertness, and then it starts declining. It's at its lowest in the middle of the night and then goes back up. So if we add our sleep drive here, our sleep drive, as I said, it starts accumulating from the beginning when we wake up in the morning. And then right here, when our sleep drive is highest and the circadian rhythm, it's not its lowest, but there's a big gap here in our sleep pressure and our circadian rhythm promoting alertness. That's when our sleep window opens. So that's where we can kind of optimize both the sleep pressure and the circadian rhythm to work together. And when they do work together, it is really effortless. We don't have to try to sleep. We don't have to do anything. It just happens. But then we get in the way, usually, of allowing this natural process to happen. So our arousal system, it can overtake our sleep drive. It can overtake our circadian rhythm, and it has that function for a particular reason. So if we think evolutionarily, if we're in a cave and we're really tired because we're out hunting for a long time and it's in the middle of the night, so both our sleep pressure and our circadian rhythm, they're both really, really strong doing what they do. But a saber-toothed tiger comes in, right? We need some sort of mechanism in our body to say, it doesn't matter how strong your sleep drive is. It doesn't matter where you are in your circadian rhythm. You need to get up and you need to function. So we have this arousal system, which allows us to function regardless. And the trick, though, is that, this can be like actual emergencies, like in the middle of the night, if you had to get up because your car alarm was going off, your smoke detector is going off, you've got a child who's crying for you. All of these things are like actual kind of, or it could be actual emergencies that you need to be awake for. But other things are not actual emergencies. They're things that we worry about. There's things that we're concerned about. There's things that we think, our beliefs that we have, the expectations can produce that same sort of arousal reaction when it's not necessary. So for example, here's a, cartoon where, a person's going to sleep and her brain's there saying, all right, let's revise some of the dumb stuff you said today. This could take a while. And that's at 10:30. At 11:17, the brain says, oh, just quickly, remember that argument from 6 months ago, right? And then after that, the person's going like, what now? The brain is whispering, you're going to look really tired in the morning. So if anybody's had, some trouble sleeping, can relate to that. Like the mind can turn on, we can start thinking about things, we can be ruminating about what has happened in the past, we can be worrying about, what's going to happen in the future. And once that happens, it can be really difficult for us to fall asleep. So this is when we get into something called insomnia. So insomnia is something that can range from just the occasional night of sleep difficulty, like everybody kind of has the occasional time where they might have some difficulty sleeping, to something that happens more chronic. So we get symptoms versus syndrome. Somebody with chronic insomnia, that would be a disorder that would be characterized by a dissatisfaction with sleep quantity or quality. And it would be characterized by if it takes you more than 30 minutes to fall asleep, if you're awake during the middle of the night for more than 30 minutes, if you wake up too early and you can't get back to sleep. That's what we would describe as insomnia. And if it occurs at least 3 nights per week, despite adequate opportunity for at least 3 months, that's when it moves from being a symptom to a syndrome or a disorder. And it needs to be accompanied by distress and impairments in daytime functioning. So between about 30 and 50% of cancer, people who've been diagnosed with cancer report difficulties with insomnia. And this prevalence really depends on what type of cancer you were diagnosed with, the time, whether or not you were in treatment, whether you were post-treatment, and how they assessed, whether it was just like a single item question on, do you have any difficulty sleeping, or, whether it was an actual, diagnostic interview. This is about 3 to 5 times higher than the general population. So we know that individuals with cancer have more of a problem with insomnia than other people who haven't had an experience with cancer. And there's a number of reasons for this. Some of them aren't going to be surprising to any of you. There's an increased prevalence of anxiety and depression, which can have, which insomnia can go along with both of those conditions. The administration of chemotherapy has been associated with a disruption in those circadian rhythms, as I mentioned. So there's evidence that with each successive administration of a chemotherapy cycle, the difference between night and day, that sort of distinction between day activity and night activity becomes blurred. There's more activity at night and less activity during the day. So it can actually disrupt circadian rhythms that way. Medications, particularly steroids, if you're not warned that, you might have some difficulty falling asleep, that can cause significant distress, and that distress can create a long-term problem. Hormonal treatments can cause hot flashes or worsen hot flashes. And then there's other factors, just, maybe pain from treatments, overall discomfort, fatigue. So, it's again, with all of those things considered, it's not surprising that we have, this prevalence. So sleep really matters. It matters a lot in recovery. We know that insomnia can aggravate both physical and mental health symptoms in people who have been diagnosed with cancer. So we know that it worsens your pain, worsens your fatigue, and it makes your anxiety and depression worse. There's some evidence that it might increase risk of infections. And even 10 years out, it can contribute to overall poor quality of life. When we look at the absence of sleep complaints, and so this would be something characterized by like consolidated sleep, and that would look like, few awakenings, that's associated with an overall reduction in mortality in women who have been diagnosed with metastatic breast cancer. So it's something that, shouldn't be, just sort of wrote off as an inconvenience. There's some really effective interventions for insomnia, and that's another reason to take it seriously. So the American College of Physicians actually put out a guideline to suggest to the physicians that all adult patients receive cognitive behavior therapy for insomnia as the initial treatment for chronic insomnia disorder. So this means even before trying medications, they are endorsing this behavioral intervention before trying medications. They do say, though, that, should benefits, costs, availability of interventions, all of these things should be considered with the patient to determine, which approach would be best used. So what exactly is cognitive behavior therapy for insomnia? And generally, it's something that targets specific behaviors which we know interfere with sleep. And so here's this cartoon that says, I spend all day hunched over a desk, railing coffee, staring at a glowing screen and reading the news. And for some reason, when the sun sets, I can't seamlessly transition into calming down enough to fall unconscious. So obviously that's an extreme case, but there are a lot of things that people do unknowingly that can get in the way of sleep well. And also there's a lot of worries, concerns, and thought patterns. So I do a lot of thinking before I go to sleep. I play scenes in my head. I practice the things I want to say. I have endless what ifs. I make plans for the next day. I think of all the people I miss. I think of all the people I hate. I ask myself a lot of questions. So you imagine if you've got all of that going on in your brain, it's very hard to transition to sleep. Now, there's the way that we explain how insomnia develops and how it's maintained in the context of cancer is with this sort of model. So down here at the bottom, you see like time, right? So premorbid is no trouble. Acute is just, trouble sleeping for 1 to 2 weeks. Short term is 2 weeks to 3 months. And then chronic is more than 3 months. And this is the severity of insomnia. And so here's a threshold over which, insomnia would become a problem. So everybody has certain predisposing factors, which makes them more likely to experience insomnia. Women are twice as likely to experience insomnia than men. If people tend to be a little bit more reactive to stress, if people have a genetic risk for insomnia, a family history of insomnia, all of those things don't change really. So those stay risk factors no matter what. But in about 75% of cases, there's a precipitating event. And a lot of times it's surrounding the cancer diagnosis that can kind of put you over the threshold for experiencing insomnia. But the challenge with a lot of people with cancer is they say, my cancer diagnosis was 4 years ago. And yes, I experienced insomnia then, but why do I still have insomnia even though I've completed my treatments? I'm in a different space now than I was then. So the impact of the cancer diagnosis, does go down. It doesn't leave you completely, but it does go down. But then what happens in the meantime is we start building perpetuating these things that we intend to help us, but they actually make it more likely that the insomnia is going to stick around. So these are things like going to bed earlier, trying harder to sleep, because that doesn't work. It could be sleeping in on weekends, and we know now why we shouldn't do that, and that doesn't work. It could be taking sleeping medications. It could be drinking, alcohol. It could be starting to worry about sleep. All of these things, if you repeatedly pair your bed night after night after night with unsuccessful sleep experiences, you end up developing a conditioned arousal, which is why people with insomnia will say, I have no trouble falling asleep on the couch. I can fall asleep on watching TV. I have no trouble falling asleep on the couch, no problem. But then as soon as I go to bed, my mind turns on and I start thinking about everything. That's an indication of conditioned arousal. It might not happen then at the beginning of the night. It might happen in the middle of the night, where reliably you wake up at 3 o'clock and your mind turns on. And it's these like habits that our mind can get into after this repeated pairing. And it happens in other areas of our life too, right? If you repeatedly pair your favorite chair in the living room with snacking. You might have just finished supper, but all of a sudden you find yourself in front of the television and you feel like you want something in your hand, you want a snack. So the same thing can happen if you repeatedly pair your bed with unsuccessful sleep experiences or other things, other arousal producing activities such as worrying, thinking, eating, planning, watching TV, like all of those activities other than sleep. So I do have a number of rules to kind of send you home with. One of them is to wake up at the same time, regardless of how many hours you slept, including weekends. This is really hard. People want to sleep in. They want to try and catch up on sleep, but catching up on sleep backfires, because if you catch up on sleep that morning, you're just going to pay for it the following night. So it creates this kind of circle of sleeplessness. You need to take the hit that night so you can try and get it recovered the following night. So you can fall asleep at your normal time the following night. And with that, you want to make sure that you get enough morning light exposure within about 1 hour of waking up. Now, this can either be outside light exposure, or it can be something like a light lamp. So that can be really helpful. We often try and avoid the things that we don't want to think about. And what happens is we, push it away until we're at the end of the day, we have nothing else to distract ourselves with, and that's when the thoughts come. And then what people do is they try and distract themselves in bed. They'll have the TV on, they'll be trying to scan through their phone or something like that. They just can't be alone with their thoughts. And so it might be tempting to try and avoid, but it's much better to address. So designating a clear your head time sometime earlier during the day, where you're actually going to start doing some of the problem solving, the planning. You can even set aside, all right, I'm going to just worry. I'm going to set aside this time. I'm going to worry. What do I have to worry about? And then just set your worry time and say, at least, okay, I already worried about that earlier. I don't need to worry about this at night. My rule number 3 is to establish a 90-minute buffer zone before your intended bedtime. So for example, if I'm a 7, a midnight to 7 sort of sleep window, at about 10:30, I'm going to shut off my devices. I'm going to spend time, I'm going to dim the lights. I'm going to spend time doing something that's sedentary, pleasant, relaxing. No backlit activities during this time, because the light, it may be impacting your production of melatonin, but it's also just engaging the light with your devices and the phones and whatever else it is, it's keeping you engaged. So making sure that you're in dim light, sedentary, pleasant, and doing something relaxing. The other one is to not spend time in bed trying to sleep. The more you try, the less likely it's going to get that you're going to sleep, because you're just going to be frustrated. So if you're not asleep within about 30 minutes, or you find yourself getting ticked off or frustrated, it's best to get up, go to the place that you've designated as your buffer zone area, and then try and resume sleep as soon as you find yourself getting sleepy again. People don't want to try this because they think it's not going to work. So they end up spending more time frustrated in bed than if they just would have cut off that frustration and then went and, even closed your eyes somewhere else, or listened to an audiobook or a podcast, and then when they find themselves nodding off, then go back to bed. The other thing too is we start to catastrophize. We start to really worry about the effects of a poor night's sleep. And the more we worry about 1 night's sleep, the more it's going to turn into 2 nights sleep and 3 nights sleep and 4 nights sleep. So, trying not to stress about a poor night's sleep, really trusting in your body to be able to regulate itself. It does a very good job when we don't intervene. So emphasizing the ability to cope with the effects of poor sleep. Now, the challenge is once insomnia is chronic, when that chronic pattern has been established, it doesn't usually go away on its own. So, treatment is indicated at that time. So we do have a study going on in the Atlantic provinces called the Action Study, addressing cancer treatment related insomnia online in Atlantic Canada. So anybody in the Atlantic Canada who has had a previous cancer diagnosis, has insomnia, has trouble with their memory, concentration, or attention, they can contact us and see if they're eligible to participate in a treatment program. The treatment is developed to be delivered virtually. So there's lots of perks about that as well. If you are interested, there's the phone number down here at the bottom and the email. But there's also, if you're not a resident of Atlantic Canada, there's some books that you can get. They're both with Canadian authors here. Judith Davidson is out of the University of Queen's University, and Colleen Carney is at Ryerson University. So both of these can be purchased at your bookstore, or maybe rented from your library. Sometimes even the cancer centers have lending libraries for patients that way. So I've come to the end of my content here.